An article published this week in AJR looked at abbreviated breast MRI for supplemental screening in patients with dense breasts. The study focused on a comparison of baseline and subsequent screening rounds by abbreviated breast MRI. The abnormal interpretation rate was 17.4% for baseline rounds versus only 7.8% for subsequent rounds. The PPV2, PPV3, and cancer detection rate were not significantly different between rounds. I'm Andy Rosenkrantz, editor-in-chief of AJR, and I'm here today to discuss the article with its first author, Dr. Christine Edmonds, assistant professor of radiology at the Hospital of University of Pennsylvania. Dr. Edmonds, thanks for joining us.
Thank you so much for having me. It's great to be here this afternoon.
To start us off, can you tell us about your breast imaging practice?
Sure. So I am one of 10 breast imagers at the Hospital of the University of Pennsylvania. In addition, we have two other downtown hospitals that we closely collaborate with. So all together, reading our MRIs in this group are 18 of us. Most of us are fellowship trained breast imagers, and the large majority of us do exclusive breast imaging. We are associated with a tertiary care cancer center here at Penn. And so we have a big team of breast oncologists and breast radiologists all here practicing together.
Can you describe how your institution has implemented abbreviated MRI for supplemental screening?
Sure. So we began looking into this a number of years ago at the point that it became clear that women with dense breasts in particular are probably in need of supplemental screening, but there was no clear test at that point that was the overwhelming choice. And really that conundrum remains today. So should we be screening with ultrasound, contrast mammo was just taking off, and abbreviated breast MRI was really promising. The problem is there's not a code or reimbursement for abbreviated MRI. There weren't initially strict guidelines on what even constitutes abbreviated breast MRI, other than it should be short, typically 10 minutes or so, or even less. And it should have a single post contrast sequence. The other issue is that because insurance won't reimburse it, we have to figure out how we can introduce it in a manner that is affordable, but also make it as equitable for as many patients as we possibly can. So, therefore, we looked at what was standard of care for supplemental screening locally, which was ultrasound, looked at the costs for that, including what patients often had to pay for a copay, et cetera. And oftentimes, because it was not mandated by the state, patients had to pay out of pocket for ultrasound. So, therefore, we set a cost that was actually a little bit lower than a screening breast ultrasound, so that therefore any patients who wanted um, supplemental screening and could at least afford an ultrasound would have access to it. So that's how we set it up. Again, with the goal to be 10 minutes or less, so single post contrast sequence, as is now standard for abbreviated MRI. And we have a T2, and those are the primary sequences.
It's great that your institution has been doing this, but what has been the main criticism to the use of MRI for supplemental screening?
Well, the criticism, some of the criticisms between abbreviated MRI and full breast MRI are shared. So a big one is cost. Of course, MRI is expensive. Access is a problem. Lots of places don't have MRI available at all. Even if it is available, there can be long wait time. So some of those challenges are what abbreviated MRI seeks to address. Much shorter exam time that should increase access. It should also improve patient tolerability of the screening exam, because we know from data that one of the reasons patients who need MRI, even those who are at elevated lifetime risk, it's because they simply don't like the exam itself. It's an uncomfortable position. It's a full MRI is a long exam, typically around 30 minutes. So abbreviated MRI addresses some of those criticisms. It does not address all of the criticism. So the other main criticism of breast MRI for screening is the high abnormal interpretation rate. So that means that we are recommending a lot of follow up or BIRAT 3, particularly on that first round or baseline breast MRI, and a lot of biopsies that turn out to have benign results. And so those not only delay patient care if you were doing a breast MRI for a reason that's not screening, but in screening patients, it increase costs, increase patient's time, the clinician's time, et cetera. So that is a big criticism of screening with breast MRI.
Turning now to your present study, can you summarize for our audience the study's main takeaway?
Yes, absolutely. So we were seeking to address a couple main points. First of all, we wanted to look at, of course, the cancer detection rate. Multiple studies have sought to look at that before. And what we know from prior data is that abbreviated breast MRI does have a very high cancer detection rate, much higher than what is typically done for screening in the normal population, which is, of course, mammography. However, there's very little to no data showing what the cancer detection rate is on those subsequent rounds of screening, meaning incident rounds, if you will, any rounds that are after that baseline round. So we wanted to see what the cancer detection rates are on those subsequent rounds, how they compare to those baseline rounds. And then, second important thing was we wanted to see if there was a change in the abnormal interpretation rate. We would expect, or we would hope at least, that that abnormal interpretation rate would go down on subsequent scans. Meaning, because we have a prior, we know what that patient's baseline looks like, we are able to assign less BI-RAD 3, therefore recommend less follow up, and hopefully also recommend fewer biopsies, so fewer BI-RADs 4s and 5s. And fortunately, we did show, in fact, that that abnormal interpretation rate did significantly go down on subsequent rounds compared to baseline MRIs.
And how are these results different from prior literature on abbreviated MRI for supplemental screening?
Yeah, great question. So, what our results show that really agrees with prior studies. Now, of course, the big one that a lot of you are probably familiar with is that big prospective trial. Some of the results are still forthcoming. So that's the ECOG Akron 1141. That study gave us great data showing that abbreviated MRI in patients with dense breasts, but who are at otherwise average risk, meaning they don't have any strong family history, mutations like BRCA, et cetera. So those average risk patients with dense breasts, that study showed us that the cancer detection rate is notably higher from abbreviated MRI compared to screening mammography, including with tomosynthesis. So our results agree with that. Our data also shows some of the first data. It was one of the first investigations to look at how cancer detection rate compares on those subsequent rounds. And so we see that it is a little bit lower on our study, not significantly lower. And so that part is primarily new data, not a lot on prior studies to show that in, also in agreement with other breast imaging studies in general, not just for breast MRI, but breast mammography, et cetera. We do see that similarly to those other studies, the abnormal interpretation rate does come down for subsequent rounds of abbreviated MRI, which is very reassuring.
In the article, you speak about optimal screening intervals for abbreviated MRI. Can you tell us more about this and what you recommend?
Yeah, that is such an important question. And I think one of the key pieces of information that we still really need to investigate when we're considering any MRI, including abbreviated MRI for supplemental screening. So, from our data alone, we really cannot make a strong recommendation for any particular interval. And I would say that that is also true of all of the studies to date. Nothing yet has been able to really guide us on an appropriate interval. I will say that what our data shows is that it is quite possible that it is reasonable and perhaps even better to have a screening interval longer than 1 year. So 1 year comes to mind, of course, because that's what's been very thoroughly investigated with screening mammography, and that's what we stick with at this point. And so that's what everyone comes to when they first introduce a modality. They consider using it annually for screening. While we did not investigate this prospectively, and therefore we did not test or compare different intervals, what we do see is that the average among all of our patients who had multiple rounds was around 2 years between studies. And if we also look at the mean in the patients who were diagnosed with cancers on subsequent studies, that mean was also around 2 years or even longer. And six of those seven patients who had cancers diagnosed on subsequent round MRI had 2 years or nearly 2 years between their studies. In combination with that is the important fact that all of those 7 cancers that we diagnosed on subsequent rounds were very early stage. So the largest was 1.2 centimeters among the invasives, and all of them were no negative. So this suggests that we should be thinking about pursuing a screening interval that is probably 2 years, potentially even longer. But this study, most importantly, lays the groundwork to test whether that is the case and really to guide investigation of appropriate screening interval for abbreviated MR.
Although the cancer detection rate was not significantly different between baseline and subsequent rounds, readers may still wonder since the detection rate showed a non significant decrease from 8.9 per 1,000 in baseline rounds to 12.1 per 1,000 in subsequent rounds. Any comment on that?
Great question, and something that needs further investigation as well. So there are, of course, two possibilities. One possibility is that there really isn't truly a statistically significant difference between cancer detection rate on baseline or subsequent rounds. The second possibility, and what I think is very likely going on here, is that simply we don't have enough patients. It wasn't a big enough study to show a true difference. And so more work is needed there. The ECOG Akron 1141 final results will be coming out at some point in the near future. They did present some preliminary results at ASCO last year, where they looked at their cancer detection rates on baseline and then on their subsequent rounds. Now, theirs was a prospective study, so all of their patients have a 1 year time interval, and their cancer detection rate, not surprisingly, went down. Again, that's a short screening interval with a lower cancer detection rate. So maybe that is again hinting at the fact that we need a longer interval between rounds of scans.
Also, the discussion section comments on a very low frequency of follow up screening rounds of only 21.2% of the study sample. Why may that frequency have been that low?
Another good question. And I don't know for sure, but we have a few ideas. Again, one of the main reasons to pursue abbreviated MRI, as opposed to a full or complete standard breast MRI, is the fact that the scan is notably shorter. So it's about 10 minutes, again, compared to 25 or 30 minutes, even longer at some other institutions for a full scan. We know patients have poor adherence to screening with full breast MRI protocols, and part of what is cited is they simply don't like it. It's uncomfortable to be in that position, perfectly still for that time. So we had hoped that adherence would be better with abbreviated MRI, meaning patients would tolerate that exam, they wouldn't mind it, and they would come back. What is tricky, though, is that we as radiologists are not recommending any specific interval for when to return. We're not even firmly, and at the point of this study, we were not even making definite recommendations that patients should undergo supplemental screening at all. So there are multiple decision points here. The patient and their clinician need to decide if they even want supplemental screening. Then they have to decide what sort of supplemental screening they want. And then if they're going to get it, they're making their own decisions about the intervals. And similarly, there is no prompt, no reminder from the electronic medical records, nothing in the mail, et cetera, to remind them that they are due for their supplemental screening, since it really is a choice and there's no clear guidelines on what to get, when to get, how often to get it, et cetera. And again, the second possibility is that the patients tried it and they didn't like it for whatever reason. I'm curious about that. I am uh, largely for that reason, I'm going to get one myself in the near future because I want to understand what it feels like, how uncomfortable is it, et cetera. I'm curious if that plays a role. So more data needed, even simple survey data would help address that important question.
And to close, is there anything that you're doing differently now based on these findings?
What we are doing differently now is we are in the preliminary steps of working with our institution, but also with the state and insurance companies, because I'm in Pennsylvania, and Pennsylvania, as of recently, has mandated supplemental screening for women with dense breasts, especially those with extremely dense breasts, but also heterogeneously dense breasts and any other risk. What that means is that full MRI is now typically covered. Insurance will cover it for those patients. part of the appeal of the abbreviated MRI program was that full MRI was not covered. And so we could offer abbreviated at a low cost. The problem here now, or what is complicated, is that we don't have data to compare abbreviated MRI to full MRI. We really don't have much of that data in general, and we certainly don't have it in the subset of patients who have dense breasts but are at otherwise average risk. So we are in the early stages of figuring out how we are going to investigate those pieces so that first we know what is superior, what we should be offering to our patients who have dense breasts but are at otherwise average risk. And then second, how do we go about if it does turn out to be, that abbreviated MRI is equivalent, and I would assume probably even better in terms of specificity and perhaps better in terms of lower abnormal interpretation rates. How do we go about getting that covered by insurance? And so those are the next steps that our institution is in the early stages of addressing.
It'll be interesting to see where those efforts go. Dr. Edmonds, thanks again for being here.
Thank you so much for having me. It's been really fun to speak with you.